Okay, yeah, thanks everybody for joining us tonight. And um, Sarah and I thought we would talk about kind of some shoulder injuries that we see commonly in the summer with all the activities that we do. Um, just want to thank Rachel for getting this set up, and also the Vail-Summit Orthopedic Research Foundation as well. And again, I think we'll talk for 20, 25 minutes and then have 20, 25 minutes of questions at the end and try to get everything answered for you guys. Um, so shoulder injuries, the four that we're going to concentrate on tonight are, I think, the most common that we see with someone falling off their mountain bike or falling, hiking or kayaking injuries or rafting injuries or tennis or other things that we all do and enjoy in the summer. And obviously we're going to concentrate on shoulder tonight. Maybe we'll do some knee stuff at another time, but these are not totally unlike injuries we might see with wintertime activities as well. But there are some nuances certainly, and we see some injuries more so in the summer than the winter and vice versa. But just some basic shoulder anatomy, first of all, just to explain that some of the terms you might hear. So this is the bony anatomy. And basically, when we say the shoulder, what we're really talking about is what we call the glenohumeral joint. And the glenohumeral joint is basically the glenoid, which is the socket, which is a part of our scapula. And the humerus is the humerus bone, which is the arm bone, we would say, I guess, not the forearm, obviously the upper arm bone, known as the humerus. And then you have your collarbone, your clavicle. We have ligaments that connect all these structures, not all of which are shown here. And then things like the rotator cuff. From a prior webinar, this is one I showed, but there's 4 rotator cuff muscles and tendons. That's what comprises our rotator cuff. And so looking on this left view, this is looking at someone from their back side. The supraspinatus is here on the top. The infraspinatus is here, again, on the scapula, originating off the scapula, the teres minor. And then if we look at someone from the front, the subscapularis is in the front, and we see, again, the supraspinatus on the top. So, and then we have to, I just threw this slide in there just to remind us all that in the shoulder, there's nerves and there's arteries, veins, ligaments that are not all shown, but all those other structures exist. So we'll start just quickly with rotator cuff disease. And again, I'm sorry if I'm a bit redundant. On a prior webinar, we concentrated solely on rotator cuffs, but I got to throw it in there because it's a very common shoulder injury that we see, particularly in summertime activities with overhead sports. So just a little bit there. There's really a spectrum with rotator cuff disease. It starts at the lowest end with like a bursitis, a subacromial bursitis, but you hear the term bursitis. But honestly, there's synonymous terms with rotator cuff tendonitis or impingement syndrome. Those are all really a catch-all term that really refer to the same sort of thing. And it's really an inflammation of the bursa and or the tendon, the supraspinatus tendon in this case, deep to the bursa, that people get impingement. And a lot of people's impingement pain is out in this lateral side of the shoulder. Typically it's chronic. There's not particularly necessarily an injury that brings it on, although if you were real active over the weekend and you painted your ceiling all weekend or something like that, you might develop something acutely like a bursitis from overuse. That's certainly, we see that. Then there's rotator cuff tendon tears, where actually someone gets a tear of the tendon. And in this case, we're seeing a tearing of the supraspinatus tendon, where obviously these tendon fibers are not hooked onto the bone any longer. And that's a rotator cuff tendon tear. So in patients who have rotator cuff problems, typically the classic things are pain at night, like pain that wakes you up at night. Again, pain here on the side of the shoulder. That's where you're going to tend to feel it, or in the front, sometimes in the back, but more so on the side, the front. Not so much on the top or on the neck. That's not typically, honestly, coming from one's rotator cuff. And that's just how the rotator cuff is wired, that you're going to tend to feel it on the side or the front more so. And then weakness. Particularly people say, I'm trying to lift something out of the fridge, or, reach in my shelves and grab something, and I just feel like I can't lift this object any longer. It's just my shoulder feels weak. And causes, a lot of this is just you and I all getting older. I mean, a lot of it is just wear and tear, and there's going to be some degeneration of the tendon over time. That's the most common cause. And if I went out there and grabbed 100 people off the street and put them in our MRI machine and looked at the rotator cuff on an MRI, we would see that fair numbers would have rotator cuff problems, and a lot wouldn't necessarily know it, honestly. But we would see that in our fifth decade of life, about 13%, in the sixth decade, about 20% of patients, and so on. So, and what the reasons that we see these problems is that there's, as we get older, sometimes there can be some vascular compromise. We just don't have quite the blood flow that we once had. Again, the tendons have worked for many years to lift things and play sports and things, and that wear and tear change in the tendon is present. But again, most people with even partial tears or a full tear even may not know it, which that's okay. If not necessarily do we need to do anything, but just my point is here, it's common. But then the rotator cuff tendon tears can happen with injuries, and the two most common that we see are shoulder dislocations, some clavicle fractures as well, although mainly shoulder dislocations is the big one. And people that fell off their mountain bike and dislocate their shoulder over the age of 40, 45, we get concerned, could there be an associated rotator cuff tendon tear? Not usually at the age of 20. Someone that's playing college football and they dislocate their shoulder, they're typically not going to tear the rotator cuff. But as we get older, beyond our 40s, 50s, a shoulder dislocation can oftentimes also indicate an associated tear of one's rotator cuff. And so again, a progression from inflamed tendons to partial tearing to full tearing, to then you get the tendon retracting and pulling away from the attachment site. And then you get this replacement of the muscle cells with fat cells. So that's how we see this progression over time. The risk factors, as I mentioned, overhead sports, overhead lifting. So a lot of tennis players, weight training, people that have been pushing heavy weights in the gym for a long time, maybe doing master swimming for years and years, painters, carpenters who just use their shoulders for their living. Smoking compromises blood flow to tendons. That can be a predisposing factor. Physical exam in the office, we're going to just look at it and look for muscle atrophy, check one's range of motion, check the strength in the rotator cuff, get some imaging like x-rays and an MRI, typically. This is a typical MRI of what we might want to see. And so there's the humeral head, that's the socket, the glenoid. The whiteness that you see, that's inflammatory fluid on an MRI. Here's one's rotator cuff muscle, that's the supraspinatus. This is one's tendon, but that tendon should be attached way out here, and it's not, as you can see. So most of the time with rotator cuff disease, if they're partial tears or inflamed tendons, it's not surgery, it's sending you to Sarah and getting physical therapy, possibly an injection, possibly some oral anti-inflammatories, modifying activities like maybe getting you out of the pool. Instead of swimming 3 days a week, we're get you on your bike or doing some other things. But if there's a full tear, we tend to push people to surgery depending on their age and activity level. Physical therapy and surgical management have been both shown to improve symptoms. However, tear size, muscle atrophy, fatty infiltration is likely to progress without surgery if there's a full tear. And again, this isn't a partial tear, this is those full tears. So, and then we've seen that if we get a full tear to heal, which we have a good chance of achieving in surgery, that we get improved outcomes over not treating something surgically. And we usually see these tears in people that are of working age, and if we don't get them back to those activities and their jobs, it's a huge cost to society. So it's worth doing. So yeah, throughout this talk, I'm going to show some occasional videos or pictures, and I don't want, is someone that maybe doesn't want to see that sort of stuff, maybe you can look away or be aware that sometimes I'm going to show some surgical video or pictures of x-rays and things, and just want to make you aware of that. So this is, for instance, a torn rotator cuff tendon. So we're looking in the shoulder. This is the torn tendon up here, and it belongs down here on the bone. You can see there's no tendon attached in this region. That's the after picture, after we've gotten it all repaired back down. So that's what we might do, something like that in surgery. This is another torn tendon. And we can see I have an instrument on it where I can pull it back into position where it belongs. And then this is a picture after where it's using suture anchors, it's reattached to its attachment site. Okay, now changing gears, shoulder dislocations. So this is an x-ray of someone I saw not too long ago. This is their emergency room x-ray because they went to the emergency room because they were in severe pain. They had fallen off their bike, had this dislocation. And you can see that, so here's the ball down here and here's the socket over here. And so things are not aligned. And they have what we call an anterior glenohumeral joint dislocation. So where the ball is anterior to the socket. And that's how most people dislocate out the front. The ball comes out the front, usually from falling on an outstretched arm and hand, landing like that, trying to brace yourself, and then the ball is levered out the front of one's shoulder. People can dislocate to the back. Like I had a patient in the office recently who unfortunately had a seizure, and his muscles contracted so abruptly and so forcefully that it actually pulled the ball out of the back of the shoulder. So you can dislocate out the back, but the front is much more common. Here's someone in surgery, and sorry for the background noise, but obviously this patient is asleep. So I'm just gently examining their shoulder, but you can see how unstable that shoulder is. I can just easily push their shoulder right out the front. And then this is a CT scan of a different patient that you can see not only did they tore their ligaments, but they actually chipped the socket, and their shoulder is really, really unstable when you as I say, chip the socket. And I tell people your shoulder joint's kind of like a golf ball and a golf tee. And you can imagine that if you chip the golf tee, the ball just falls off. It doesn't even stay on there. And so the bony anatomy is critical to a joint stability, and then the ligaments as well. But if you tear the ligaments and chip the socket, those are the patients that walk into their office like this. They're like holding their arm and hand when they see me because they're afraid to let go because they know the ball's just going to slip right out. But here's what we oftentimes are accomplishing in surgery. So this is looking at a socket, and basically here's the labrum, it's called. And I tell people the labrum, I have all these simple analogies, but my analogy, it's kind of like that orange gasket on a mason jar. You can peel it off the edge of the socket when you dislocate. So when the ball is sitting in the socket here and the ball comes out the front, it just rips these ligaments off the front of the socket. And in surgery, what we're doing is we're putting little anchors in the bone, and off of those anchors come suture that then are looped around the labrum, and we're sewing the labrum back up to the edge of the socket. Whereas once that labrum was like hanging in the breeze out here, we're sewing it back up to the edge of the socket. So this is one in surgery again, where here's the socket, here's the ball, and the ligaments are way over here. And I have this instrument, you can see I can pull them away from the socket. And that's the before, and then that's the after picture. Sorry for all the bad background noise, but that's the labrum after it's fixed in place. Okay, so then the third topic, shoulder fractures. And again, when we say shoulder fractures, that's not the best term because you can fracture your clavicle, you can fracture your acromion, you can fracture your scapula, you can fracture your humerus. So most people, when they fracture their shoulder, or really what they're fracturing is their proximal humerus. And that's, again, you're fracturing your arm bone up here, which not uncommon. We'll see it in, nationwide, when we talk about proximal humerus fractures, the main population that is affected is typically elderly females. So like a 75-year-old woman who has osteopenia, osteoporosis, unfortunately slips in their kitchen, falls on an outstretched hand, breaks their humerus right here. And that's the typical patient. In our population, we see that, but we also see tons of young people who are 20 and launch themselves off a jump in the terrain park and land on their humerus and fracture. But they fracture entirely differently. They just explode their bone, whereas an older person, the bone is kind of soft and it just kind of crushes the bone. So the fracture types are different, and we see them in younger people just because the things we do out here, the crazy things we do, that there's much higher energy when one falls, off their mountain bike going 20 miles per hour than someone that just falls in their kitchen. But here's one, this is a simple one. So this is looking right at the humerus bone here. And so here's the socket. And you can see, I don't know if you guys can see the fracture here, but it's right there, right across what we call the surgical neck, right below the ball. That's a common place to break right there. But in this case, this person is going to do fine without surgery. Everything's lined up reasonably well. The bone is shifted just slightly here, but this is one that I wouldn't recommend a surgery for. We treated this person in a sling. This was their x-ray about 3 months later, and they're all healed and they're doing great. So not everyone needs surgery for these. It really depends on how significantly displaced the bones are. If the bones have really shifted out of position, then we have to kind of put things back into alignment. This is one that's more displaced, and this person fell and dislocated their shoulder. So they dislocated their shoulder, but they also fractured as well. And this is a very common pattern because this piece of bone right here is where the rotator cuff attaches. And when the ball comes out the front so forcefully, the rotator cuff kind of rips this piece of bone off. And this is the after picture after their shoulder is back in position. And in this case, the bone landed, and this is not unusual, this type of fracture. We call this a greater tuberosity fracture, where again, the rotator cuff inserts here, but when the ball is placed back in the socket, this piece tends to fall into position. And this is another one that I wouldn't recommend surgery. This person's going to do okay just letting this heal. But this one is not going to do well. This person not only dislocated their shoulder, but as you can see, they fractured right here, and the ball and the socket are just not even in the ballpark. And we put this ball back in, but this has to, I can't pull on this patient's arm to put this person's socket back in. So this is one we have to open surgery, put the ball in place, and then fix the humerus, the shaft to the ball. So, and this is, they end up with something like this, where we get the ball, as I say, we get the ice cream back on the cone, and then we put the plate on and screws to hold it all in position. So it's nice and solid, and then we can start in physical therapy with Sarah, they can start moving their shoulder right away, because the big risk with these injuries is people get stiff. And if we don't get them into physical therapy and get them moving right away, they'll heal it fine, but they'll end up saying, wow, I'm healed, but my shoulder's never been the same. It's just super stiff. But if we can get them stabilized with a plate and screws like this, and then send them to Sarah and get their motion back, they're going to do fine. They're going to do well. Okay, lastly, clavicle fractures, very common. Just fixed another one yesterday. I see a ton of these. Not all of them need surgery. Again, usually people falling on a mountain bike, falling skiing, falling in the terrain park. That's the kind of typical story. Most fractures are like this one, where here's the collarbone. The collarbone goes from about here all the way to out here. Most people break right in the middle. You can see this one's splintered a little bit. We say it's comminuted a little bit. It's in a couple little pieces, but the good news is that the bone is pretty lined up. And what we do is we measure how displaced it is. And so we're really measuring the distance from the top of this bone, once lined up with the top of this bone. And we measure that distance of displacement, or we say displacement or shortening. And if it's more than about 15 millimeters, so a little over half an inch, tend to fix them. They just do better. When we look at thousands and thousands of patients and follow them in our literature, we just find that they do better fixed. However, if I had that fracture, I might just get my partner to fix it day one, because I want to get back to work within a couple weeks. And so if I get stabilized right away, I'm much more functional more quickly, honestly. But this is one that I would offer patients the opportunity to say, hey, just leave it in the sling, let it heal. You're going to heal. It just is going to take a couple months. So, and that's how this person did. We treated them without surgery, and they made all this extra bone and bridged the bone and healed it really well. So. But this is a CT scan of one. So this is kind of a weird view, but here's the collarbone on the inside, and here's the collarbone to the outside. But these pieces, you can see how splintered and displaced they are. That's what we usually see around here in our population. Just points to the amount of hard falls and all the crazy things we do. This is how most people break their clavicle, and they split it into 4 pieces. So a piece on the outside, piece on the inside, and then these 2 pieces that are at 90 degrees to the other bones. And that one's not going to do well without surgery. You can see how shortened the bones are. Like this one, in this bone, they're not out to length. The bone is kind of like, it's splintered and it's like this short. And so it might heal like that, but long-term people are not going to do well with it because they get this shortened shoulder syndrome, and they don't have the normal biomechanics of their shoulder. So they're not going to have a great shoulder. Are they going to heal? Yeah, but they might say, I've had some weakness and some chronic pain in my shoulder if we don't fix that one. And that's this is kind of what we use to fix it, is these special plates. And the plates are made, they're basically designed so that they perfectly match the contour of our clavicle. And then they have these, what we call locking screws, where the screws actually thread into the plate. And it's just a really strong construct where, as a result, we can get people in physical therapy and moving them right away and rehab them faster when we use these special implants that are super strong and designed for a specific fracture type. I think that's my part. I'm going to turn it over to Sarah.
Sounds good, thanks. So I'm Sarah Campbell. I work as a PT in our Silverthorne Avalanche Clinic. Go ahead and move on to the next slide.
Okay, sorry.
So I'll kind of talk about the PT role in all of this. So a lot of times, if you're private insurance, you can come straight to a PT if you feel like your shoulder is injured. Obviously, if you have a fracture, you should probably go get an x-ray of that first before coming to see us. But if you're just having that kind of like bursitis, or you've had chronic dislocations and you want to see if exercises will kind of help before reaching out to a physician, you're more than welcome to come see us with our direct access through commercial insurances. If you have Medicare or Medicaid, you're going to need a script from either primary care or an orthopedic doc to come see us. So yeah, we're trained in all sorts of special tests that the orthopedist can do to kind of rule in different injuries of the shoulder, soft tissue injuries, so muscle, labrum, stability, all those kind of good things we're trained in measuring and testing. And then after like a clavicle injury or an AC separation, you might want to come see a PT, because we can tape for clavicle fracture and acute AC separations and make it feel better for that period of time you are immobilized. So really can come see a PT for any injury, whether it's broken, we can tape it, or we can kind of diagnose and get you on the road to starting some exercises to start feeling better, even if you're waiting to see an orthopedic or your primary care. Go ahead and, yep. So kind of what to expect in that initial visit. If you're having shoulder pain, we'll ask lots of questions about how the injury occurred, or if there wasn't an injury, how long pain's been going on for. Just kind of get to the root of when things started, how they started, and kind of how things are feeling now. And then we typically will measure that range of motion, see if you can reach all the way overhead, behind your back, all those kind of functional movements you need to move around just the house, let alone normal activities like biking and skiing and throwing. And then we'll kind of keep paring down, figuring out what's wrong, do some of those special tests if we need to try and figure out exactly where your pain and injury is coming from, so that we can better prescribe exercises to help you get you feeling better faster. So those initial exercises will often involve some posture muscles, because a lot of times people with shoulder injuries kind of droop in on that shoulder. So you get that bad posture. It's going to pull on the neck, it can pull lower down on the arm, affect hand function if you're really tight in the front of that shoulder. So we work a lot of posture to kind of straighten you out and get that shoulder in a better biomechanical position for reaching. And then, yeah, starting with some gentle motion, gentle strength, just trying to calm everything down initially so that you start to feel a little bit better. In the subsequent visits, we progress strength and stability to get you back to activities that you enjoy. Whether it's golfing, skiing, yoga, like those pictures there, or even just, doing gardening and working around your house. Anything that you have a goal for, we'll design exercises to make you feel better for. So yeah, we look to get that overhead motion, pain-free, normalized range, get you back to doing everything around the house, and then we'll keep increasing strength and stability based on what your goals are. So if you need a lot of strength for a specific sport, we'll keep working that strength a little bit longer than someone who might not have as high level of goals. Okay. And then if you were to have surgery and Dr. Cunningham sends you to our clinic, then typically the same process, we just start a little bit lower level, because a lot of times after surgery, the docs keep you at a passive range of motion restriction for a couple of weeks. And that's just to let everything they do heal, especially if it's a rotator cuff. They don't want you activating any of those muscles. So PT just starts stretching you and keep the shoulder moving just to avoid any complications like that stiff shoulder Dr. Cunningham was talking about. And then kind of based on what they did in the surgery, every surgery has a different protocol, and we're all well versed in that. And of course, reach out to your surgeon if we have any questions, but we'll progress you slowly into more active range of motion, getting you reaching on your own, doing all those kind of daily things again. And then again, progressing into that strength that you need for any sports and activities that you're interested in. And that's kind of the PT role. We just take what your goals are and help you to them. Yeah.
All right. Thanks, guys.
Cunningham, any questions?
Looks like we're ready for questions now. So if anybody has them, again, you can submit them to that Q&A box at the bottom. So I'm going to go ahead and get started. First question from Anonymous. Would you address early symptoms of frozen shoulder? Not sure if that's how would you address early symptoms of frozen shoulder?
Sure. Yeah, that's a very painful diagnosis, frozen shoulders. And for those people, maybe frozen shoulders where the ligaments that connect the ball to the socket basically get inflamed and then shorten, and very painful, one of the more painful shoulder diagnoses we see. A lot of people don't recall any specific incident that caused it. They just come and see us and say, my shoulder is killing me and I can't move it too well. And when I move it, I get just a sharp stabbing pain. In some cases, people will report, oh, I started a new exercise program, doing a lot of overhead pressing, or I was rearranging shelves all weekend, and then by the next week I started to get sore. So it can be an overuse incident that causes it, but in most cases there's no identifiable factor that brings it on. But yes, most people come and see us because it's so painful. And right off the bat, we'll if the pain is such that it can maybe be managed with let's say anti-inflammatory medications and Tylenol, over-the-counter stuff, we would just typically start you on that and then start you in physical therapy. But if someone said, I can't sleep at night, my pain is just so severe, then we probably would just do an injection in your joint. And that's very helpful. Most people come back from that injection saying, wow, that was great. I feel so much better. I can sleep now. And then in physical therapy, I'm making much better progress, getting that range of motion back. And so I would say, to answer your question, anti-inflammatories, over-the-counter medications to control your pain, physical therapy to help restore the range of motion, injection if needed. Most people, that course alone is effective in getting them back with good range of motion and no pain. But frozen shoulders can take like 3 to 5 months to resolve. They can take a long time. They're frustrating. I've had, I do have the occasional patient that we've injected, we've done physical therapy, the pain keeps recurring, and then we actually need to do a surgery where we release the scarred and thickened ligaments in the shoulder to get that range of motion back. But again, probably 80% of patients, 90% of patients don't need surgery for that diagnosis.
All right. Next question from Terry Nelson. I suspect a pinched nerve in the upper arm. How can you diagnose that, or could it be a muscle tear? No pain in 95% of motion, but other 5% of pain is sudden and hurtful. The pain goes away almost immediately.
Yeah, I mean, if it's really localized pain, if that sharp pain is pretty well localized, and when I say maybe with like the size of one's palm, if it's localized to that or smaller, it's probably not a pinched nerve. Nerve pain tends to be a radiating pain. Like people say, oh, I get this pain here, and it radiates all the way down my arm, into my hand, into my thumb, into my forefinger, or my fingers. That is more nerve type pain. So if it's more localized sharp pain, then it's probably not nerve pain. It's probably more tendon pain, typically like rotator cuff pain. Um, so I hope that answers your question.
All right, next question from Anonymous. Are there any typical shoulder injuries that could come from carrying something large and awkward on one shoulder?
Yes, and and that's, I think it's back to that, the fact that all of us have some wear and tear change in our rotator cuff tendons. And as we get older, those changes even turn to slight tearing, partial tearing, possibly in some cases, even full tears. And oftentimes we, are staying strong and active and we never know that there's a problem because we're compensating. And then we do something like carry heavy objects all weekend, like help our daughter move out of her dorm room or something. And carrying boxes and overhead lifting or whatnot. And then all of a sudden it's like, wow, my shoulder hurts. And that could be, in fact, a torn tendon or a partial tear, at the very least an inflamed tendon. But again, it could be actually a torn tendon that you've been compensating for and never really knew. And then one activity brought it to your attention.
All right, next question from Matthew Murray. I hurt my shoulder golfing 2 weeks ago. After ice, heat, pain not going away. Pain is reaching in the back of me, not up and down. Any therapy?
Yeah, I definitely would start with therapy. And I don't know, Sarah, if you want to take that one on.
Yeah, I mean, like I said, we're kind of movement specialists. So if you came to a therapist, we could look at that range of motion, see where it's affecting you, do some special tests. And I mean, if we find anything suspicious, we can always refer you to an orthopedist. But by coming to PT, you might be able to get some exercises that make it start feeling better and get that range of motion coming back a little bit quicker. So yeah, therapy, definitely. Those shoulder injuries. Love all the shoulders.
All right, this next one's from William. I have a torn rotator, hurts at night, weakness above my head when lifting. Does this injury always require surgery? I'm 71. Can living with it cause other problems?
Yeah, so 71, and let's say it's a full thickness tear. I mean, it's not a partial tear, it's a full tear. If someone came to me and we examined them and they had good motion and the MRI does demonstrate a full thickness rotator cuff tendon tear, but let's say they told me, it doesn't hurt that much. I'm able to do all the things I want to do. It really doesn't hurt that much. I wouldn't recommend surgery. I think I'm maybe more conservative than some. But I would explain the long-term history of these tears and what we know from, looking again at thousands of patients and how these things progress is that the tear initially pulls off the bone and then over time it starts to retract and retract and retract. And then, what we don't want to get is a situation where 2 years from now you come back and see me and you're like, well, now I can't even lift my arm. I'm so weak and it's horrible pain. And then we get a new MRI and the tear is so retracted that I then say, you know what, I'm sorry, it's too retracted to fix. I'm not gonna be able to stretch it back over and get it reattached. And so now that time frame, could it be 2 years? It could be 5 years, it could be 10 years, I suppose. But unfortunately, that's the natural history where once you tear, they start to slowly retract. And then I have the unfortunate conversations with some people that I say, it's too late. It's really, I'm not gonna be able to fix you. And then we're looking at salvage procedures, which are really, there's a salvage procedure called the superior capsular reconstruction where we can put a donor tendon in place of your tendon. However, we can't connect donor tendon to the muscle. So it's not as good of an outcome as if we could have reattached your own tendon. Or what happens after a big tear is that the ball starts to ride up and you start to get arthritis in your joint. And so the other salvage procedure is a shoulder replacement called a reverse total shoulder arthroplasty. So you know, there's other options down the road if it gets to that point, but they're not as good of an outcome as if we could have fixed your own tendon in the first place.
All right, this next question is from Jim. I had a shoulder reversal many years ago and had a bicep tear along with cumulative injury. I still experience cramping of the bicep when lifting very light weights and even while flossing. Is there any therapy that can negate this?
And I'm sorry, Rachel, I missed that first word. He had a, did you say he had a
Shoulder reversal many years ago. Had a shoulder
reversal
reversal many years ago and had a bicep tear along with the cumulative injury.
Okay, so it sounds like, if I'm understanding things correctly, that's a reverse total shoulder, which that was what I was just mentioning. So if someone has had a reverse total shoulder, a lot of times at surgery, the surgeon will just cut the biceps because it can rub over the implant and cause pain, and we don't want to leave the shoulder with any possible sources of pain. So a lot of surgeons just cut the biceps. Others take the biceps and they sew it down below into the humerus bone and kind of reattach it. And in those cases, people get a little bit better strength and they don't have a deformity in their biceps where the muscle sinks down. But if someone still has pain in their biceps, I'd be most likely, if this patient has had a reverse total shoulder, their biceps was probably cut and then it's kind of fallen down their arm. And if that was done some years ago, which it sounds like it was, probably not much to do. I mean, you know, could you open up the shoulder, explore for the biceps? I had a patient just on Friday, honestly, he was only 35 and his surgeon cut the biceps and didn't reattach it, which can be done. It's called a biceps tenotomy. I'm not a huge fan of it because some people, again, can have some residual biceps crampy pain. So I always reattach them. In this case, he was 8 months from having that procedure. We went back in, found his biceps, pulled it back up, reattach it. You can sometimes do that. I think we got a little lucky. He was 8 months out because usually by then it's all just encased in scar. If it's a couple years out, it'd be really unlikely to be able to find the biceps and pull it back up. But certainly there's other sources of biceps pain that are not just the biceps. Like people might feel it on the front of the shoulder, but there's a problem with, let's say, possibly the implant. You know, the implant might be possibly not positioned well, maybe coming loose from the bone, bad things like that, which are possible. So we'd want to see in the office and rule those things out first. And then if it was just your biceps, maybe we'd start with an injection to your biceps and see, does that help the pain or not, to confirm it is coming from the biceps and not something else. So we'd certainly want to make the correct diagnosis as a first step.
All right, next one is from Teresa Johnson. How critical is it to apply ice to your recent surgery area to improve healing, i.e. game on, as opposed to using normal ice packs? What are the benefits to using this device for 2 weeks? So I think Game On is the name of the device.
Oh yeah, probably the Game Ready. It's called a Game Ready. It's a really nice cooling machine, and it's got a pad and it circulates ice and cold around. In my case, because I do just knees and shoulders, we use them quite often, and they work really well. Unfortunately, insurance doesn't cover them, but we have a deal with our vendors locally where it's about a $20 rental per day. So it's about $250 for 2 weeks, which I think some sort of ice machine is worth it after shoulder surgery or knee surgery for that matter, especially for bigger surgeries like a rotator cuff in the shoulder, or like, let's say, an ACL or a knee replacement, something like that. I think they're worth it. You can buy, though, a cooling device online for around $100. They're not as good as the Game Ready, but you own it at least afterwards. So that's another option. But I do think it's better than ice bags and things like that. If someone's having a simple knee scope or a simple shoulder scope, you can get away with the bag of peas out of the freezer. But if it's a more sizable procedure, I think I'd go with the rental Game Ready or the purchase ice machine.
Next one is from Terry again, follow-up question. My pain did initially radiate from my hands and up my arm when I was twisting a screwdriver or unlocking a deadbolt, but that has subsided after 5 months of pain. The original injury was trying to twist off a spin-off filter on my car with my arm fully extended. I heard a noise in my upper arm, like a click, 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 no popping noise. I can still move my arm a certain way and duplicate that same clicking noise. What might be going on?
Yeah, it's certainly that history is concerning for a rotator cuff tear and or biceps tear. That history is certainly concerning for that. So I'd probably come on in and we should examine you and then get it. And most likely we're going to need an MRI scan. And insurances today don't approve MRIs without getting an X-ray. So we always get an X-ray, and we want to get an X-ray anyways. We don't want to see, do you have arthritis in the shoulder? We'll see sometimes calcific tendonitis where people have calcification of one of the rotator cuff tendons. So, an X-ray gives us some good information anyways, but that's probably what I'd recommend for you.
All right, next question is from Gary, and he said, what is your opinion on reversed shoulder procedure?
Well, yeah, I think again, in those cases where someone has, the main indication for a reverse total shoulder is someone who has arthritis in their shoulder joint and an associated rotator cuff tendon tear. And because the other type of replacement is just what we call an anatomic shoulder replacement. And with an anatomic shoulder replacement, we're basically you're getting a metal ball on a plastic socket. And a reverse is just as it sounds. Honestly, it sounds strange when we put the ball on the socket side and the cup on the humerus side. But what a reverse does is it changes the center of rotation of the shoulder to lateralize it, to move it to the outside, so that your deltoid muscle, which is still working, can optimize its function. And then people can sometimes then raise their arm overhead despite the fact that they have no rotator cuff tendons that are working. So it's a great procedure for those people that have a really bad problem, which is bad arthritis and no working rotator cuff, or very little working rotator cuff. But once you get a replacement, obviously there's no going back. So we want to make sure that we've exhausted all other options, and that's the only thing out there for you. And we wouldn't want to put a reverse total shoulder in like a 40-year-old, because they're going to wear it out prematurely, like in 10, 12 years. If someone is 70, 75 and they have that problem, they do very well. So it's a good surgery for a bad problem.
All right. Next question is from Rosemary. I am a past patient of Vail-Summit, but currently not in Colorado. I sustained a humerus fracture with minimal displacement. Surgery was not recommended. Had x-rays and a CAT scan, and am being treated with a sling, basically kept immobile and iced, other than occasionally letting my arm hang down. Minimal to hardly no pain. It has been 3 weeks with x-rays scheduled next week, and hopefully can begin PT. Also heard platelet infusion may help. Any other suggestions?
Yeah, I definitely would recommend getting into PT, and I'll have Sarah speak here, but we want to get you moving, because the biggest risk with those fractures is stiffness. So doing those pendulum exercises, which Sarah can explain, and getting you into therapy, I think it's a good idea. At 3 weeks, that we start you in physical therapy. The only other thing, your PRP, there's really no science, a good science, in terms of, where we've looked at 500 patients that have had PRP and 500 patients that have not in the setting of a humerus fracture. I would suggest that it's helpful. And what we're finding, honestly, is that, these stem cell clinics and PRP clinics are popping up all over the place. And they're really, unfortunately, they're taking advantage of patients. They say, hey, we can cure everything. Come see us. We're just going to inject some stem cells or some PRP, and you're going to give us a couple $1,000 and you're going to be a whole lot better. Well, there's just not a lot of science behind what is done. I use PRP and I use stem cells for certain conditions where there's evidence to show that it helps, but humerus fractures isn't one of them. So I wouldn't spend your money on that. I would do the therapy. And Sarah, maybe just what would you do as far as?
Yeah, usually in those first couple of visits, like I said, a lot of posture. So even before you go to PT, start like in your sling, you can start just pulling your shoulder blades back and just watching that posture, because again, that sling kind of droops you down and in and puts more pressure on that shoulder. So lots of posture before you start PT. I'd recommend seeing someone just to like kind of train you on those pendulum exercises, just to make sure you're doing them right and watching you, because also like doing some passive range motion before those pendulum exercises, just to make sure you have the range. Because again, we kind of create exercises based on what your function is. So sounds like you're already planning on hopefully seeing a PT in the next week or so they can kind of see where you're at and work you through those exercises as you're ready for them. But I'd say before then, just squeeze, lots of shoulder blade squeezes and watching that posture.
All right, it doesn't look like we have any more questions at this time. If anybody else has any more questions, please submit them now. Otherwise, I think we're gonna call it a little bit early. So just to kind of recap what our options are, if anybody would like to make an appointment with Dr. Cunningham or Sarah of Avalanche, you can feel free to call either of our clinics, or you can reply to the email that you got this invite confirmation from, or this webinar confirmation from, and let us know that you would like somebody to reach out to you. If you have more questions, you can submit them there as well. We don't always get around to more questions in the email after the fact, but the best scenario for that is probably to come in and have a consultation if you do have more questions. If anybody else has anything to add, I'll give you one more minute to submit it. Otherwise, please visit our website, and you can find all of our webinars there, along with upcoming webinars. We don't have any listed on there at this time, but keep checking back next week, because there are some more coming up that we're just in the process of getting scheduled. So I think that's all we have for tonight. Dr. Cunningham, do you have anything else? Sarah?
No, I think that's all. Thanks, you guys. Thanks.
All right. Thanks, everyone. Have a great night, and hope to see you on the next one.
Okay, bye.